Hi, my name is Dr. Oksana Moroz, and this is my presentation on the approach to urinary incontinence for NAC OSCE preparation. Please note this video is for educational purposes only. Before entering the examination room, you will be presented with a case which is attached to the door. You will have 2 minutes to read the scenario and make some notes. So let's have a look at this scenario. You are seeing a 62-year-old female patient, Mrs. Brown, in your clinic. She presents with a 6-month history of urinary incontinence. In the next 8 minutes, take a focused history. Here are some tips while you are making your notes. First of all, write down the patient's name and age. Pay attention to the setting, if it's office, walk-in clinic, or emergency department. Then carefully read the task. You can be asked to do more than one of the following, such as take a history, perform physical examination, counsel a patient or a family member, interact with physician or allied healthcare providers. Then you should write down your chief complaint, differential diagnosis, and don't forget to use mnemonics that will guide you through the history taking. Inside of the room, you will greet the patient and the examiner, introduce yourself and identify your role, confirm the patient's name and date of birth, give a sticker to the examiner, explain that you're going to take a history, and gain consent to proceed with a history. There are 5 types of urinary incontinence, and your differential diagnosis will include stress, urge, mixed, overflow, and functional urinary incontinence. Stress urinary incontinence is the involuntary leakage of small amounts of urine in response to increased intra-abdominal pressure, weakness of the pelvic floor muscles, or urethral sphincter. May be caused by pregnancy, childbirth, obesity, aging, and post-prostatectomy in men. Urge urinary incontinence is the involuntary leakage of urine that may be preceded or accompanied by a sense of urinary urgency due to the drusen overactivity. Causes will include overactive bladder syndrome, stroke, multiple sclerosis, Parkinson's disease, bladder infections, and bladder tumors. Mixed urinary incontinence is the involuntary leakage of urine caused by a combination of stress and urge urinary incontinence. Overflow urinary incontinence is the involuntary leakage of urine from an overdistended bladder due to impaired detrusor contractility and or bladder outlet obstruction. Causes will include benign prostatic hyperplasia, spinal cord injury, CNS lesions, multiple sclerosis, and diabetes. Functional urinary incontinence is the involuntary leakage of urine due to environmental or physical barriers to toileting. When you're taking history, first of all, analyze the chief complaint. You should ask the patient, when did it start? Was it all of a sudden or gradual? Is it getting worse, better, or stays the same? Does it come and go? And how long does it stay each time? If the patient is having pain, you will use PQRST mnemonic, and you will assess pain, quality, radiation, severity, and timing of pain. Also, ask the patient, how does it affect his or her life, and if it happened before. Then we have the 3 A's: aggravating factors, alleviating factors, and associated symptoms. Aggravating factors include coughing, sneezing, laughing, straining, lifting of heavy objects, sexual activity, and feeling of urgency. Alleviating factors, you will ask the patient if anything makes it better. And now let's look over the associated symptoms. The first one is obstructive symptoms such as difficulty to initiate urination, change in stream, incomplete emptying, and dripping. Irritative symptoms such as frequency, nighttime urination, need to rush, loss of control, flank pain, and burning sensation. Then assess urine changes such as color, odor, amount, and blood in the urine. Local symptoms include constipation, groin or pelvic mass, abdominal or pelvic pain, and perineal skin lesions. CNS symptoms include impaired memory, weakness, numbness, difficulty speaking, and tremors. Then you should rule out constitutional symptoms and call the Equina syndrome. Then you will use MGOS abbreviation, which will help you to find the potential cause of incontinence or to find risk factors. Then you will take past medical history. There are some examples of relevant medical conditions such as diabetes, stroke, recurrent UTIs, renal stones, pyelonephritis, chronic kidney disease, BPH, and prostate cancer. Ask if the patient is having any allergies. Then you will ask if the patient is currently taking any medications. It is also important to ask about hospital admissions, previous surgeries and procedures. Ask if there is any family history of urological disease, and explore the patient's social histories to identify potential urological risk factors. Then you will proceed to the physical examination. First of all, you should assess vital signs such as temperature, blood pressure, heart rate, respiratory rate, and oxygen saturation. On general inspection, assess skin color changes, pedal edema, jugular or venous distension, abdominal masses, and surgical scars. On auscultation, rule out pulmonary crackles, assess heart sounds. On palpation, you will look for abdominal masses and bladder distension, and then you will perform percussion. Mention to the examiner that you would like to finish the examination with the examination of the external genitalia, speculum exam, and rectal exam. You will look for vaginal atrophy, pelvic organ polyps, prostatic hypertrophy, fecal impaction, and rectal bone. Investigations will include urinalysis, BUN, creatinine, post-void residual volume, renal ultrasound, and urodynamic testing. Let's have a look at the management of stress urinary incontinence. Conservative management includes weight loss, behavioral therapy, Kegel exercises, pelvic physiotherapy, and mechanical devices. Phenylpropolamine is usually prescribed for management of stress urinary incontinence, and surgical treatment will include vaginal laser, urethral bulking, intravesical balloons, mid-urethral sling, pubovaginal sling, and urethropexy. Conservative management of urge urinary incontinence involves control of fluid intake, time to voids, and weight loss, and pharmacological involves antimuscarinics, topical vaginal estrogen, and mirabegron. Conservative management of overflow urinary incontinence includes clean intermittent catheterization involving urethral catheter, relief of obstruction, and pharmacological treatment will be taurursine and tamsulosin. These are references that I used for preparation of my video. Thank you for your time. I hope you find this video useful, and good luck on your exam.